Welcome back to the deep dive. Today we are tearing apart the playbook for fighting what is still the world's #1 killer, coronary artery disease. We're diving deep into the world of lipid management. Our mission for you really is to walk away with a crystal clear understanding of what these drugs do.
Their therapeutic actions, you mean?
Exactly, and the
Yeah.
different ways they work, their mechanisms of action.
And maybe most importantly, the safety side. The key nursing considerations for, 5 major drug classes that manage high cholesterol?
That's it.
And we really have to start with the stakes here. I mean, coronary artery disease, CAD, is still the leading cause of death in the Western world.
It's staggering.
It is. And when we talk about high lipids and the blood hyperlipidemia, we're talking about a major, and this is the key word, modifiable risk factor.
Yeah.
These antihyperlipidemic agents are the tools we use in this fight.
So let's build that foundation. How does a healthy artery become, well, a ticking time bomb? We have to talk about those plaques, the atheromas.
It's a really subtle process. It starts with some kind of damage to the artery lining, the endothelium. That could be from high blood pressure, inflammation, you name it.
And that damage is like an open door for fats to get in.
Right. It starts as just a fatty streak, but then your body's immune system responds with inflammation.
That's where you get those foam cells, right?
Precisely. The foam cells are just immune cells, macrophages, that have gorged themselves on fat. They become the core of this growing plaque, this atheroma.
So it's not just a clog, it's an active, inflamed site. Lipids, platelets, cellular junk, all building up and narrowing the artery.
And here's the really critical insight, something we've only confirmed more recently. It isn't just the size of the plaque that matters.
It's what it's made of.
It's the composition. We now know that the soft, lipid-filled cores are the really dangerous ones. They're unstable.
They're prone to rupture.
Exactly. And if that rupture happens, a massive clot can form almost instantly, and that's your heart attack. The harder, more fibrous plaques are still bad. They still restrict blood flow, but they're much less likely to cause that sudden acute event.
Okay, so that's the enemy. Let's quickly trace the path of fat in the body, starting with, say, dinner.
Right, so you eat fat. Your liver produces bile acids, which, by the way, contain cholesterol. The bile acts like a detergent in your small intestine.
Breaking the fat down into tiny parts.
Micelles, yeah. But fat and water don't mix, so those micelles get packaged into something called a chylomicron to be transported out of the gut and into your circulation.
Which brings us to the famous carriers everyone's heard of, LDL and HDL. Let's do the quick version.
Sure. LDL, low-density lipoprotein, that's the bad cholesterol. It's very tightly packed with fat. When it breaks down, it leaves behind these remnants.
And the remnants are the real problem starters.
They're thought to be, yes. They're highly inflammatory and seem to be what kicks off that initial damage to the artery wall.
And on the other side, you have HDL, the good guy.
HDL, high-density lipoprotein, it's loosely packed.
Yeah.
And its job is basically to scavenge. It's the cleanup crew. It goes around, picks up extra fat and cholesterol, and takes it back to the liver.
Which is why things like exercise are so good for you. They boost your HDL.
Right. Exercise and also estrogen, which is why premenopausal women tend to have some protection.
Okay, one more player before we get to the drugs. There's this enzyme that kind of protects the bad guy, PCSK9.
Proprotein Convertase Subtilisin, Kexin Type 9.
It's a mouthful.
It is.
But think of it this way. Your liver has receptors, like little docking bays, that are meant to grab LDL out of your blood.
Okay.
PCSK9 is an enzyme that binds to those docking bays. And when it does, it essentially tells the liver to destroy that receptor.
So more PCSK9 means fewer docking bays?
Fewer docking bays, which means your liver can't clear LDL from the blood effectively, so the LDL just keeps circulating, raising your risk. Got it. And all this biology connects to the risk factors we all know, unmodifiable ones like genetics and age, but the modifiable ones are our focus.
Diet, sedentary lifestyle, smoking, obesity, stress, high blood pressure, diabetes. It's a long list.
And that collection of factors, the metabolic syndrome.
Yes, that's a really dangerous combination. Insulin resistance, belly fat, low HDL, high triglycerides. It just sends your CAD risk through the roof. The main takeaway for anyone listening is that drugs are always an addition to lifestyle changes, not a replacement.
Okay, let's pivot to the solutions. 5 drug classes. Let's start with the one that works right in the gut. The bile acid sequestrants.
Cholestyramine is a common one. And the mechanism is, well, it's pretty straightforward. They bind with those bile acids in your intestine.
The ones we said act like detergent.
Those exact ones. They form a big insoluble complex that can't be absorbed, so it just gets passed out in the feces.
Which means the liver is now short on bile acids for the next meal.
Correct. And to make more, it has to pull cholesterol and LDL from the blood. so your serum cholesterol levels drop. And what's neat is they aren't absorbed into the body at all.
That sounds safer, but I know there are some major catches with taking them.
Huge catches. The nursing considerations are critical. If it's a powder, you must mix it with plenty of liquid. Never take it dry. It's a serious choking hazard.
And it messes with everything else in your gut.
It does. Other meds have to be timed carefully, either an hour before or 4 to 6 hours after. And because it binds things up, you can get some serious GI side effects.
And the biggest safety flag?
It's the absorption of fat-soluble vitamins, A, D, E, and especially K. If you become deficient in vitamin K, your blood can't clot properly. You can see increased bleeding times. That needs to be watched closely.
Okay, moving on to the undisputed heavyweight champion, the HMG-CoA Reductase Inhibitors, the statins.
Right. Atorvastatin, simvastatin, these work directly inside the liver's cholesterol factory.
They shut down the assembly line.
They block the main switch. The enzyme HMG-CoA reductase is the gatekeeper. It controls the rate-limiting step in cholesterol synthesis. By blocking it, you dramatically cut the liver's internal production.
And the results are huge. Lower LDL, lower total cholesterol, even a little bump in good HDL. Plus, don't they also help with the plaques themselves?
They do. Research suggests they help stabilize those soft, dangerous plaques, making them harder and less likely to rupture. That goes way beyond just lowering a number on a lab report.
And with administration, timing matters for most of them.
It does. Your body naturally makes the most cholesterol overnight, between midnight and 5 a.m. So most statins work best if you take them at bedtime. Atorvastatin is the main exception. You can take that one anytime.
But the warnings here are severe. Let's start with pregnancy.
Pregnancy category X. Absolutely not. They are contraindicated due to a high risk of fetal abnormalities.
And then there's the big one, rhabdomyolysis.
Rhabdo. It's a dangerous breakdown of muscle tissue that can flood the kidneys with toxins and cause acute renal failure.
So what do you tell patients?
You tell them to report any sudden, unexplained muscle pain immediately, especially if it comes with a fever. It's a medical emergency.
And the grapefruit juice thing? It sounds like a myth, but it's real?
It is absolutely real. Grapefruit juice messes with the metabolism of most statins, causing their levels in the blood to skyrocket. This hugely increases the risk of side effects like rhabdo.
And it's not just about timing it right.
No, the effect can last for up to 48 hours. So patients on these drugs just need to avoid grapefruit and grapefruit juice entirely. And of course, regular liver function tests are non-negotiable.
Okay, class number 3 is a perfect partner for the statins. Cholesterol absorption inhibitors, like ezetimibe.
Right. So if statins block internal production, ezetimibe blocks external absorption. It works right at the brush border of the small intestine to stop you from absorbing the cholesterol from your food.
So the liver notices less cholesterol coming in from the diet.
And it compensates by pulling more cholesterol out of the blood. It's a great team player.
Often used in combo pills, right?
Yes. Often combined with a statin when one drug isn't enough to hit the goal LDL. And it's generally pretty well tolerated.
Now for the newest and most complex class, the ones that target that enzyme we talked about earlier, the PCSK9 inhibitors.
These are a total game changer. They are monoclonal antibodies, which is a very advanced kind of biotechnology. They're designed to hunt down and bind to that free-floating PCSK9 enzyme.
So they basically act like a bodyguard for the liver's LDL receptors.
That's a great way to put it. They stop PCSK9 from destroying the receptors, which frees up the liver's docking bays to clear way more LDL from the blood. The drop in LDL can be dramatic.
But these aren't pills.
No, they're subcutaneous injections. They're usually reserved for patients who are already on the highest dose of a statin they can tolerate, or for people who just can't take statins at all.
What are the main downsides?
Well, aside from the high cost and the injections themselves, you can see injection site reactions. And interestingly, a slightly increased risk of things like colds and upper respiratory infections. And with any antibody therapy, there's always a risk of a serious allergic reaction.
Let's quickly touch on the other categories before we get to the nursing side.
Sure. You have the fibrates, which are mostly for lowering triglycerides. The big caution there is that combining them with a statin increases the risk of rhabdomyolysis.
And niacin.
Niacin, or vitamin B3. It's good at lowering LDL and raising HDL, but the side effect is this intense flushing of the skin. It makes a lot of people stop taking it. And finally, you have the prescription omega-3 fatty acids, which also lower triglycerides but can prolong bleeding time.
Okay, let's make this practical. Thinking about that case study of the 55-year-old workaholic, for a patient like that, what's the educational focus?
For a goal-driven person, you have to frame it in terms of achievable goals. The drug is just a tool. It's an adjunct to lifestyle change.
So you don't say change your whole life.
No, you say, let's start with a 30-minute walk every day. You leverage that personality, you give them short-range goals they can hit, which builds compliance and confidence.
For statin users specifically, beyond the muscle pain, what else?
We tell them they need regular eye exams. There have been some reports of cataracts with long-term use, and we hammer home the grapefruit juice rule. For the sequestrants, it's all about managing constipation and timing those other medications correctly.
And all of this is useless without the follow-up labs.
Absolutely non-negotiable. You need to track the lipids to see if the drug is working, but you also need to monitor for toxicity. We need those liver function tests, the AST and ALT, to catch any problems early.
And just a quick look across the lifespan, what about kids?
For children, it's almost always diet first. But some statins are approved for specific genetic conditions, usually in kids over 10 who are past puberty.
And for women of childbearing age?
Because statins are category X, the bile acid sequestrants are the drug of choice if a medication is absolutely necessary. And for older adults, the general rule is start low, go slow with statin dosing.
That brings us full circle. 4 really distinct ways to lower lipids. Statins block production inside the liver.
Ezetimibe blocks absorption from your food.
Bile acid sequestrants force excretion through your gut.
And PCSK9 inhibitors supercharge your liver's natural ability to clear LDL from the blood.
It's a complex playbook.
And it has to be, because there's no single cause of CAD. The only way to succeed is to tackle multiple risk factors at once. That means combination therapy and, more importantly, strict adherence to those lifestyle changes. That's what really moves the needle for patient outcomes.
Which really raises an important question for you to think about. The guidelines now push for getting LDL cholesterol below 70 for very high-risk patients, which often requires that combination therapy we just talked about. So considering the huge cost and complexity of the injectable PCSK9 inhibitors versus the cheap oral statins, how should our health systems prioritize these different tools to ethically and sustainably get all their high-risk patients to that aggressive goal? Thank you for joining us for this deep dive. We hope you feel a little more equipped to navigate this very complex field. We'll see you next time.